Good evening, and I welcome all the students and colleagues to the 33rd class in this edition of Up-Aroi MD teaching schedule. And our guest faculty for the evening would be Dr. Swaroopa Mitra, who is a senior consultant at Rajiv Gandhi Cancer Institute, Delhi. And ma'am has been always interested in all academic activities, both in the national level as well as in the regional zonal chapters. So today she will be talking about management of recurrences in cancer cervix as well as other special cases. So it's quite a long path to cover, and I hand over the mic to ma'am. Ma'am, please take over. Thank you.
Good evening, everyone. Good evening, sir. And I am so thankful. I feel so privileged to get this opportunity to be able to speak on a subject which I actually practice. And just like sir had said, it is a lot of learning as I prepared my slides. So I thought I learned a lot more. Okay, so before I start, I would like to confess something. That I had started building on the slides thinking that it would be something to do with the recurrence in cervical cancer, in advanced cancer. So I had began preparing that way, but only yesterday I came to know that I should be talking about challenges which we face during the treatment of carcinoma cervix, and very rightfully so. So I did try at 10 o'clock in the evening, I started preparing the slides, and I hope I have done justice to them. The topic is so important. And if there are some misses, I would really request to be excused. So I begin with the carcinoma cervix, dealing with recurrences and the other challenges. I'll begin with the recurrences first, and then after that, I'll be talking about the other challenges which we face in our day-to-day clinics. So if anybody has any questions among the students, so you can ask me in the end, or you can put them in the message box. So, this is a 46-year-old patient who underwent chemoradiation therapy for a recent cervical cancer. I'm sure this is a very, very common presentation. We all come to see these type of MRI and images so commonly in our practice. After 2 years, she has a recurrence. An MRI has been done, which she has done probably from outside, and this is what the findings are. So it shows this is the sagittal section and the axial section, and we see a soft tissue mass in the cervix, which has extended posteriorly to the rectal wall, which is seen with this arrow, and has caused luminal narrowing. And also you can see some bullous edema in the bladder wall. And so you can see there is a luminal narrowing also. So this is a very familiar picture, and we all come to face this. This I would say it is a challenge. Now, the questions we ask to ourselves: how to deal with these patients? What are the investigations shall we do? What are the treatment intentions? Should it be a curative treatment or a palliative treatment? And what are the treatment options? The case I showed is a hypothetical case. This is just to actually bring ourselves to think about such cases and many other such cases of recurrences which we come to see in our OPDs. So what is the definition of recurrent carcinoma cervix? As I was reading, there were many definitions, and this is one which was given in 2013. Recurrent carcinoma cervix is defined as a local tumor, regrowth, or development of lymph nodal or distant metastasis at least 6 months after the primary lesion has regressed. Recurrence following primary surgery has been reported to be about 27%, and the recurrence after chemoradiotherapy demonstrated a recurrence rate of about 32%. So let us begin with a small introduction of carcinoma cervix, because this is the cancer which is very close to our home. One of the most common causes of female cancer-related deaths among women worldwide. Recurrence rates we can see in the earlier stages, 1B, 2A, it is about 11% to 22%. 2B to 4A, it rises to 28% to 64%. Whatever the stage is, the treatment of recurrent cervical cancer is a challenge. Prognosis is poor. 5-year overall survival less than 5% despite intensive therapies, particularly in in-field recurrences. Let me caution, this is an old data, and every day we are progressing a lot. We are doing much better in recurrent carcinoma cervix as well. Now, what are the frequent sites of recurrence? If we categorize them, it can be local or central pelvic, it can be regional, it can be distant. Local means it includes the recurrences in the vaginal vault alone. It can be in the cervix, in the uterus, and the parametria. Regional is when they are around that area. So it can be anterior, that is, invades the bladder, ureter, urethra. Posterior in the rectum, anal sphincter, or lateral also, invading the pelvic side walls, vessels, nerves, and involving the pelvic lymph node stations. We call it distant when it is the para-aortic lymph nodes, including the infradiaphragmatic, the supradiaphragmatic local recurrences, and also the distant organ metastasis, the lung, liver, and the bones. So these are generally the sites of recurrence or metastasis which we see. The patterns of relapse, the most frequent patterns of recurrence are local, vaginal vault, or the regional. And the commonest type is the central type. But let me again remind you, in the retro-embrace, it has shown that there's improved pelvic control, and it has actually unmasked ocal distant disease, making the distant alone relapse and the predominant as the predominant form of failure. So this is what we have seen. There is a change over the years. Now, this is an old study, so you can see it is long back in 1999. I have placed it to show how much we have gone ahead when we talk of cervical cancer. According to this study, the pelvic and the para-aortic, there was 75%, 62%, lungs were 33 to 38%, liver 33%, peritoneum 5 to 27%, and so on, and the skin also about 10%. Now, this is a study which is in 2016. This is the details of the recurrent sites after definitive radiation therapy. I am talking about the recurrent sites because our treatment will depend a lot according how the recurrence is. So according to this study, the local disease was a major type of intra-radiation therapy pelvic field recurrence. While the para-aortic lymph node control was favorable, according to study, even in initially para-aortic lymph node positive patients. So the predominance of outside radiation field recurrence alone highlights the issue that concerning the distant control, that is distant control is important, including the intensity of enhancement of systemic therapy. So this is to stress that we are almost nearing that the local control is much better, and we have to now concentrate on the distant control. Now, coming to the topic, what are the symptoms and signs of locally recurrent cervical cancer? It can be many, actually. So sometimes it may be no symptoms at all. So there may be vaginal symptoms like discharge, bleeding. There can be dyspareunia or a pain, a deep-seated pain over there. And when we do a pelvic examination, a mass or a nodularity at the vaginal cuff may be present, and which may extend to the pelvic wall and may be visualized or may be palpated. Sometimes we cannot visualize it, but we can palpate it very well. Now, disease within the vagina or the vaginal vault can be tender to palpation and may be prone to bleed. Many times we do not see anything, but when we touch it, the patient shrieks with pain, and on palpation there can be a bleed also. So these are very typical findings of a locally recurrent cervical cancer. Now, what happens in a metastatic cancer? Again, it can be no symptoms at all, and it can be a non-specific symptoms, fatigue, nausea, weight loss, and symptoms related to the site of metastasis. Here, I'd like to quote one patient which I saw today. She was lost to follow-up for a year. She was a carcinoma cervix patient treated about 2 years back, and she was lost to follow-up because of the COVID. And she came absolutely no symptoms. She had no symptoms, but just because she was a 3A disease initially, and then there was a long gap. We did a PET scan, and lo and behold, we saw a large mass in the chest. It was 6.9 centimeter. And I kept on prodding to her, do you have any symptom? And she denied. So this is just that there can be no symptoms at all. How do you diagnose? Biopsy is a must. However many times a patient says, in Indian patients, they keep on saying, no, biopsy nahi karana hai, biopsy se cancer phailta hai, but no biopsy. We have to convince them that biopsy is a must. MRI is required, CT scan, PET CT is sometimes required. And what are the recommendations? However much good MRI scan or the PET CT scan we have, the clinical examination is absolutely necessary, especially in cervical cancer, be it a recurrent or a de novo. Please do not underestimate a clinical examination. So visual inspection essentially through the clinical for a thorough clinical staging is a must. MRI is the preferred imaging technique. I'm sure we all know this by now. And the DWI, it increases the sensitivity. FDG PET scanning should be carried out to rule out any distant metastasis. So these are all we should know, that if we want to diagnose a recurrent or a metastatic carcinoma cervix. Now, MRI, we all know this is becoming more and more important. It is indispensable if we want to treat a carcinoma cervix patient. Why? It is because it is reliable in differentiating recurrences from post-treatment changes in the pelvis, which is previously treated. This is very important. Many times it is very difficult to estimate whether it is a recurrence or some post-radiation changes. MRI helps us in that. Accurate evaluation of the recurrent tumor extent and nearby organ invasion. Detection of the pelvic and the para-aortic lymph nodes, at least a T2 weighted images in sagittal, axial, oblique, or coronal oblique orientation is required. Residual or regional lesions. So this is how we do it in the MRI. So there are some recommendations, or we have the contrast enhanced DWI MRI protocols. So I have just noted them. It is a large chapter, but it is a very good chapter. But this is what I found, the MRI protocol. So all students, please go through them. Now, management of local recurrence. I'm going to talk about the local recurrence and separately about the metastatic disease. Local recurrence. Now, how do we, when such a patient comes in, how do we manage them? The choice will depend on some of the criteria of prior treatment which the patient has received, the site of recurrence, and the PS, or the general status of the patient. So broadly, there are many more factors which I'm going to discuss, but these three factors should be in our mind whenever we are talking about treating a patient who has come with the local recurrence. Prior treatment means any prior treatment. Site of recurrence, where is the site of recurrence, and the general performance status of the patient. Other things is that prior treatment, the patient may have received a radiation therapy or may not have received a radiation therapy. All those who have received a radiation therapy, hysterectomy or a pelvic exaggeration or re-radiation is a choice. All those who have not received a radiation therapy or who are not surgical candidates, for them radiotherapy is a choice. So broadly, anybody who has received a radiation therapy and a recurrence is there, surgery. And for all those who have not received radiation therapy, or even those who have received radiation therapy but are not surgical candidates, radiotherapy is a choice for them. So let us discuss the surgical options. Whatever the circumstances, the surgical options are, if the patient comes after a CTRT, that is with the uterus conserved, then what are the surgical options do we have? A radical hysterectomy or a pelvic exaggeration. The 5-year survival rates are between 30 to 40%. Now, if the patient has come following a hysterectomy, then in that case, pelvic exaggeration, of course, vaginectomy in selected patients, and intraoperative radiotherapy. We do not have much data about the importance of intraoperative radiotherapy, but yes, this has been discussed as an option. Now, what are the criteria for surgical resections? When a surgeon selects a patient, what does he or she see? Very important is that for any surgery, curative intent, it cannot be a palliative intent. A curative intent with a complete removal and negative margin, this should be the aim. If it is palliative, then no, there's no need of surgery. A central or pelvic recurrences without any side wall fixation or associated hydrouteronephrosis. So the disease has to be a central pelvic recurrence, maybe small in size, a tumor in 3 centimeters, somewhere it says about 2 centimeters in diameter, and it should not be fixed to the side walls, and it should not be associated with the hydrouteronephrosis. A long disease-free interval is always what we want to have, but the longer the disease-free interval, it is easier to treat and the prognosis is much better. So when we talk of pelvic exaggeration, once again, I reiterate that exaggeration should not be used as a palliative treatment at all, except for some malignant fistulas and some similar situations. And when do you take the final intraoperative, final decision whether to go ahead with exaggeration or not? This is done after the assessing the whole abdomen, and you see inside, utilize the frozen sections, and only then you decide the final decision whether the exaggeration needs to be done or not. Contraindications, absolute contraindications, are metastasis to the extrapelvic lymph nodes, metastasis to the abdominal viscera, metastasis to the lung or the bones. These are absolute contraindications. The relative contraindications are obesity, pelvic side wall spread, that is direct extensions or nodal metastasis, and the triad, the famous triad we have always studied: unilateral ureteropathy, non-functional kidney or ureteric obstruction, unilateral leg edema, and sciatic leg pain. Now, what are the non-surgical options? Non-surgicals are the radiotherapy and the chemotherapy. Of course, we are going to lay our focus on radiotherapy. Now, if it is the recurrences following a CTRT, that means a CTRT was given, and after CTRT, there is a recurrence. In that case, we are blessed these days. We can do a re-radiation even with a brachytherapy or with external beam also. We have the option of the stereotactic radiations, of which the data is coming up. But yes, I would like to discuss this, that stereotactic radiotherapy is a choice for re-radiation. Now, if the patient has come after a hysterectomy, then EBRT and CCT with brachytherapy is a choice. EBRT and stereotactic body radiotherapy, brachytherapies, all these permutations and combinations are the options that we have for such patients. So there are plenty of options. Now, candidates for chemotherapy. Candidates for cervical cancer, chemotherapy is not still so much in use as the first line of treatment, but those patients who are not a surgical candidate or for salvage radiation, then probably they can be taken up for chemotherapy, but I don't know how many of such patients will be fit for chemotherapy. Now, criteria for re-radiation or radiation, what we need to see and focus is that the site of the recurrent disease, whether the recurrence is infield or outfield, the size of the recurrence, how big is the recurrence or how small is the recurrence, the time to recurrence, that is, when has it come back? Is it 6 months after the radiation previous treatment, 1 year, 1.5 years? So the time to recurrence is very important to decide on the treatment. Details of the previous radiation. This is very, very important. Many times we do not have them, but we should strive our best to get the previous radiation. They will be done with some of our colleagues in any part of India. And these days, it is not at all difficult to get hold of these by talking to our colleagues in other hospitals. So please get the details of the previous radiation. Any history of prior surgery needs to be evaluated. Of course, we should not be over-enthusiastic. The patient's general condition is very, very important. A long gap, like I said, between two radiations is always welcome. Now, the recurrence, I'm going to talk about the treatment under different headings. The first is the recurrence, which comes when the recurrence comes after a previous chemoradiation. That means the patient has already been treated with CTRT and the patient comes back with the disease. So the recurrences could be central recurrence, vaginal recurrence, lateral recurrence, and in-field isolated recurrence. So you can see all these recurrence sites, how important the recurrence site is. The treatment may vary. So let us talk one by one about each of them. Now, a central pelvic recurrence after previous radiation, what are the options we have? Of course, the patient has received radiation. So the first option that comes to our mind is definitely give her the option of radical hysterectomy. Now, in a small cervical cancer recurrence, the 5-year survival rates are 27 to 72%. Of course, there are some previous studies which says that there's a high complication rates, sepsis 9.8%, fistulas 48%, but this Rubin et al. Study is a good study, but it is a considerable number of years back. Pelvic exaggeration is an option, and it should be a curative option only. The favorable prognosis, the patients who would have a favorable prognosis are free surgical margins, negative lymph nodes, small tumor size, and long disease-free interval. So for central pelvic recurrence post-radiation, hysterectomy is a good option. Now, if there is a vaginal recurrence in previous radiation therapy, we can give a small field radiation therapy, although she has received a radiation therapy, but taking into considerations the selection criteria, we can give a small field radiation therapy to the whole vagina without the pelvic lymph nodes, because the pelvic lymph nodes have been treated already. Brachytherapy boost is provided either with an intracavitary brachytherapy or interstitial implant. Here, once again, I will take the opportunity in saying that SBRT or SRT is still not the replacement of a brachytherapy. There's nothing as good, as beautiful as a brachytherapy. In selected cases, brachytherapy alone, usually interstitial brachytherapy, is a good way to treat such patients. If we give EBRT, then 40 to 45 grays, of course, taking into consideration the previous radiation dose and the dose to the OARs, brachytherapy 24 into 4 grays or 15 grade 3 fractions for interstitial. So these are the various schedules or radiation therapy doses which can be delivered. They have to be customized. Now, coming to the lateral pelvic recurrence, we were talking about the central pelvic recurrence. So now the lateral pelvic recurrence in a previously radiation-treated patients. Now, these patients are traditionally very difficult to treat. Traditionally, they have been considered as unfit for exenteration, and they usually receive palliative chemotherapy. Again, I'm saying traditionally, no more so. For surgery, there are other options which have been attempted, like the laterally extended endopelvic resection. So this has been attempted, neoadjuvant pre-exenterative chemotherapy. These are all attempted, but we still do not have much data that how far they can be given. I'll talk later on. There is SPRT or a local radiation therapy for these kinds of recurrences is an option, is a very good option. Now, isolated recurrences in the previous pelvic radiation. So this includes the lateral radiations also, like I have said here. Central recurrences, if it is a central recurrence, retreatment with brachytherapy, either intracavitary alone, or if you are good at doing interstitial, yes, interstitial, these are beautiful ways to treat for a central recurrence. A sidewall recurrence, like I said, it is still not in the NCCN guidelines, but I don't think the day is far that we will have them in the NCCN guidelines. SBRT or SABR have been implemented, have been used with good good results. And there are recent publications which have gone to higher doses. And not only SBRT or ACBR, even IMRT with hypofractionation has been used. Now, this is a study. This is a very recent one. That is why I thought I should include this. This is in 2021. Radiotherapy for vaginal recurrence of cervical cancer patients after prior surgery. So they have included 141 patients. They have received EBRT in the most advanced techniques with VMAT and TOMO with a GTV dose between 30 to 80 grays. So that means this is the ideal way they have been treated. So yeah, so these are the doses that have been used. So it is possible to treat with radiotherapy after vaginal recurrences, and there are good ways you can treat it with a good 5-year overall survival and progression-free survival and local control rate, as we are seeing them over here. So they're very good. Now coming to the next arm, that is the recurrence, where no prior radiation has been given. So probably a surgery has been done. So for these central or lateral pelvic recurrences post radical hysterectomy without any adjuvant irradiation, these are the group of patients which are also quite frequent in our OPDs. So for these patients, we have the option of radiation and CTRT, cisplatin-based, and this is actually the treatment of choice. The vaginal vault relapse radiotherapy and brachytherapy is also added. Now, here we come with a word of caution. Please be very, very careful for delivering radiation therapy or CTRT to these patients, although they have not received radiation before. Why? Because the safe delivery of high-dose radiotherapy should be our priority. Now, the post-surgical lutetians, you do not know where she has been operated and how she has been operated. So the post-surgical lutetians can be plentiful, and they actually increase the radiation dose to the bowel because the bowel are no more moving and they're stuck here and there. Lymph node metastasis can be often associated with a systemic spread of the disease. We have to keep this in mind, that if there are lymph node metastasis, there could be a systemic spread of the disease. So these are the things which we need to keep in mind. Now, hysterectomy without adjuvant radiation, where the hysterectomy has been done without adjuvant radiation, then operable disease, but they do not opt for pelvic exaggeration. Here, 5 and 10-year survival rates are 43 to 33% respectively, and the pelvic control rates are 69 to 62% respectively, and the predictors of good outcome here are a high brachytherapy dose. So all studies have said that a high brachytherapy dose is it is actually a good predictor of outcome. A long treatment-free interval between the primary surgery and the recurrence, needless to say, this is very, very what we sought for. This is also a situation, isolated para-aortic recurrence. This is quite common. And I think as we are seeing more cases, these types of cases are becoming more and more common in our OPDs. So you can see the incidence of definitive treatment in such cases, they are still should be considered for definitive treatment, and the incidence is about 2 to 12%. Median survival related to the disease-free interval, 7.5 months who failed less than 2 years versus 17.8 months for those who are more than 2 years. So the disease-free interval is very important. Concurrent chemoradiation, with concurrent chemoradiation for these patients, 5-year survival rate, you can see 51.2% to a very daunting 100%. So this is in 2005 in the Red Journal, it has come out. Now, summing them up, so these are some of the recommendations in practice I have taken from the British Gynecological Cancer Society and our own NCCN. Now, the British Gynecological Cancer Society, the recommendations they have for locally recurrent carcinoma cervix is discussion through MDT and tumor board. The more I emphasize it is probably less. They have to be discussed in the MDT. In selected cases, re-radiation may be advised, but with increased risk of late toxicity. Surgical excision of isolated nodal recurrences should be discussed whenever appropriate. FDG PET imaging is essential before the procedures are discussed. Now, in short, they have said that recurrent pelvic disease post-surgery, then CTRT or resurgery. If it is if the recurrence is post-RT, very simple. And if it is central pelvic, then surgery, exentration, hysteroscopy, and palliative chemotherapy. They have not mentioned radiation therapy over here, but yes, we can do post-radiation sidewall or extrapelvic recurrences, then pelvic RT, chemotherapy, and best supportive care also, because there can be situations where nothing is possible. Now, what does our good old NCCN say? Now, NCCN 2022, this is almost like the same thing, local regional recurrence, no prior RT or failure outside the previously treated radiation field, consider surgical resection. They have individualized EBRT and systemic chemotherapy and brachytherapy. And if a prior radiation has been done, a central disease, then pelvic exaggeration, intraoperative RT, IORT, they have as a kind of treatment option. And also if that is less than 2 centimeter, hysterectomy, and yes, we have brachytherapy over here. And probably later, like I said, SBRT is not mentioned anywhere else, but probably in days to come, we would have. If it is a non-central disease, that is, it is a lateral pelvic wall disease, then individualized EBRT treatment, IORT, systemic therapy, and probably SBRT also in days to come. Now, next, we were talking about the local recurrence. Now, what about the metastatic disease? I'm not going to talk a lot in detail. I'll just scrape through them. So our main idea is that management of metastatic disease in carcinoma cervix, is there a role of radiotherapy? Normally, when there is a metastatic disease, we always rule out metastatic disease, finish, no role of radiation, please go to the medical oncologist. But is there a role of radiotherapy which is coming up? So it depends on the extent of the disease at presentation, limited metastatic disease, extensive metastasis. So now we are having criteria like limited metastatic disease, oligometastatic disease, and extensive metastatic disease. So for all other cancer sites, the treatments have been individualized, but not yet in cancer cervix, but soon we will have, I'm sure. So this is a very nice paper, local radiotherapy or chemotherapy for oligorecurrent. So this is a term we have now, oligorecurrent cervical cancer patients with prior pelvic irradiation. This is exactly what we are looking for, and we are looking out in future. So this is in 2019. So the results said that local radiotherapy showed superior local recurrence-free survival, but inferior disease-free survival. This is very interesting. We were talking in the first 2 slides that we have to focus on our disease-free, that is the distant metastasis. So here we are, local radiotherapy. It does show superior local relapse, but inferior disease-free survival, and we have to do something about this. There was no significant difference in overall survival, so you can sleep over that. Now, multivariate analysis revealed that FIGO stage at initial diagnosis was associated with a good overall survival for patients with early FIGO stage 1B, 2B. Local radiotherapy provided a tendency towards a longer overall survival than chemotherapy did. Outfield oligorecurrence in patients with initial early FIGO stages may be an indication of salvage radiotherapy, and this is a take-home message for us. So, metastatic disease, out of field, but oligorecurrence in patients who were initially in the early FIGO stages could be an indication for salvage radiotherapy instead of sending them to chemotherapy. But again, I will hold myself because we still have to talk about the disease-free survival. We have to increase that. So this is what it showed. This is again a continuation of the same study. That is, what is the implication of the study in our present day-to-day practice? Compared to chemotherapy, local radiotherapy was associated with better local control, but yes, sadly, worse distant failure. The discrepancy between the survival is in the early years of follow-up. Chemotherapy now here, the chemotherapy can be added to radiotherapy to control microscopic disease in high-risk cases. This is what we need to think over, whether even after radiation, and such cases are discussed in our tumor board. After the radiation, we have started using local radiotherapy in such cases, but there is always the dilemma whether we should go ahead with the chemotherapy adjuvant or concurrent with it or not. So this study says probably chemotherapy can be added in such cases. The initial advanced stage and not the number of recurrent sites is a negative factor for overall survival. So oligometastasis, oligorecurrence, the number is probably not so much of a negative factor as the initial advanced stage is. So out of field oligorecurrence in early stage carcinoma cervix may be a curable disease. That is a take-home message. Now, one or two small slides, SBRT. We all are very enthusiastic about SBRT, and we are using everywhere in almost all sites, but still not so confidently in cervix. So let us see what our astro say. Treatment intensification using radiation therapy in local and metastatic sites, especially with SBRT, has shown promising results with improved overall survival and progression-free survival. So here comes ESTRO and the URTC, the expert group. They have classified oligometastatic disease into oligorecurrence, oligoprogression, oligopersistence. So even oligopersistence is a new term. So with all this, we are looking at a brighter future for cervical cancers which are recurring. So there is a project for OligoCare, which is a prospective project, and anyone can accrue patients. They have started accruing patients for this project. So you can open this and see how they are doing. So this is the dose, median cumulative dose of 100 gray suggested without much toxicity in a patient previously treated with radiation therapy. So this is a very interesting concept. Now, what about overt metastatic disease? They are not recurrent, not oligometastatic, not oligopersistence. They are overt metastatic. Chemotherapy plus bevacizumab. Again, I'm not going to talk about them much. Incorporating bevacizumab improves overall survival. Chemotherapy naive have higher response rate than with prior chemotherapy, including chemoradiation, but cisplatin is still the most widely used agent. These are just a few points that for us to keep in mind. There has been several GOG trials. The first GOG trial regarding chemotherapy was way back in 1981. After that came the GOG 110. There are several others. And now we have the recent, the GOG 240, which does say that there is improved survival by the addition of bevacizumab. So between these trials, these are the list of GOGs which we have and which have actually paved the path for what we are today, that we are looking up to for in a metastatic cancer cervix. Now, what are the prognosis? What is the prognosis for patients, such patients metastasis? Prognosis is still poor. Overall survival, median survival after diagnosis about 10 to 12 months. Factors influencing survival are performance status, race, interval between the diagnosis and the recurrence, prior chemotherapy, platinum-free interval. We always see our medical colleagues, medical oncology colleagues, talking about platinum-free interval less than or more than 6 months. So this helps them to decide what kind of treatment to be given for metastatic cancer cervix, location of the recurrence, in-field recurrence. And to end all this, we must remember quality of life must be a consideration during treatment planning, any treatment planning. We must not compromise on the quality of life of the patient. Now, this is all about the recurrence and the metastasis. Now we are talking about some challenges. I was told later on that pregnancy in cancer cervix need not be done, and I agree that this is a large chapter, but since I had already prepared, I'll just add a few points to remember, not the details, a few points in pregnancy cancer cervix and a frozen pelvis, which is important. After that, I'll talk about the challenges. So I think I'll finish by 9 o'clock. So this is a cervical cancer and pregnancy. Now this is, you can see some very nice pictures of a baby inside the utero, and a MRI has been done at 22 weeks and 31 weeks. So pelvic MRI at 22 weeks, you can see with a cancer cervix, and here also in 31 weeks, there is a mass in the cervix. So these images I have just placed here to get ourselves interested in the topic. So cervical cancer in pregnancy, just a few points. It is the most frequent malignancy diagnosed during pregnancy. Fortunately, most patients are diagnosed at an early stage. Management during pregnancy depends on a number of factors: stage of the disease, tumor size, and lymph node involvement, duration of pregnancy, histological subtype, patient's desire to continue with the pregnancy, desire for future childbearing. Oncologic outcome of cervical cancer patients is like that of the non-pregnant patient. This is important to remember, that the oncologic outcome of the patients who are suffering from cervical cancer, it is same as those non-pregnant patients. So these are some of the points for us to remember. Delay in treatment of the cancer to achieve fetal viability is an option for early stage cervical cancer. Radiation is associated with spontaneous abortion, congenital malformations, and pediatric malignancies. Hence, it is not routinely recommended during pregnancy. So no radiation during pregnancy with cancer cervix. Expectant managements are feasible when the pregnancy is near term, as the fetus has reached maturity. NACT is an alternative to CTRT option to delay definitive treatment until fetal viability. Platinum-based chemotherapy, most frequently used treatment. Chemotherapy during the second and the third trimester is associated with IUGR, intrauterine growth retardation, prematurity, and the low birth weight. Chemotherapy within the 3 weeks of anticipated delivery is not recommended. So these are a few points which we can remember in our day-to-day practice. Mode of delivery, what should be the mode of delivery? Most patients, they undergo cesarean section, planned vaginal delivery in the setting of microinvasive disease. It can be done. Vaginal delivery in the absence of a confirmed diagnosis is not associated with disease progression, obstetric complications, or decreased survival. So this was all a few slides about pregnancy in cancer cervix, and now about frozen pelvis. So this is, I think, more of these patients we used to see when we were doing our MDs. Now they have reduced, but it is not that we don't see them. We do see them for different reasons. So advanced carcinoma, which have spread extensively, causing a frozen pelvis or distant spread, is generally beyond cure. So this you see, this is a study in 1965. So at that time, advanced cancer with the frozen pelvis were supposed to be beyond cure, and they were sent for best supportive care. Now, what is a frozen pelvis? This is a surgical condition, the definition says, where reproductive organs and adjacent structures are distorted by extensive adhesive disease and fibrosis, which obscure the normal anatomical landmarks and the surgical planes, making dissection extremely difficult and increasing the risk of injury to vital organs. So this is what a frozen pelvis is. What are the causes? It is not only cancer, infections that cause adhesions, pelvic inflammatory disease, any past surgeries, including removal of an ovary, benign and malignant growths. Endometriosis is a very important cause of frozen pelvis, and also our radiation therapy to pelvic areas. Of course, not so much with IMRTs, but yes, previous radiation therapy did used to cause frozen pelvis. Now, what are the symptoms? The symptoms are distressing, severe and significant changes in bowel habits. If somebody has seen a frozen pelvis patient, one can never forget that patient. She comes with severe, significant changes in bowel habits, including constipation with episodes of diarrhea, painful bowel movements, and bloating. And these symptoms might be caused by bowel obstruction because, as I said, all the organs and everything, they are stuck to one another. There is frequent urination, even at night. There's a trouble holding urine, flank pain caused by the obstructed ureter, severe leg pain. I think I feel, this is my personal feeling, probably this is the commonest which we see in our OPDs, severe leg pain and radiating pain to the sciatic. So these, I think, I see these patients more probably. So these are the common symptoms of frozen pelvis. Diagnosis by manual examination. This is an intraoperative picture of frozen pelvis. By manual examination should be coaxed. The patient should be persuaded, be very gentle because it may be quite painful, very distressing for the patient. So very, very gentle and coax the patient to get a pelvic examination done, because only by the pelvic examination, you touch the pelvis and you know it is a frozen pelvis. You cannot be mistaken. Transvaginal ultrasonography, if you cannot, sometimes it may be too painful and the patient will not allow. A transvaginal ultrasound may be tried. MRI pelvis, of course, is an answer to everything. Treatment of frozen pelvis. Now, like I said, frozen pelvis used to be treated, even now, it is taken as a state where nothing is possible. So it is a terminal event. But nowadays, with more of data, more of experience, more of research, hysterectomy in frozen pelvis is challenging. But yes, I have seen many places where they have been done, whether done by laparotomy or laparoscopy. It is not impossible, but yes, it is challenging. It is done often by an open retroperitoneal approach with adhesinolysis. Adhesinolysis is also done as you do any laparotomy. Palliative radiation therapy. When nothing works, these patients are sent for palliative radiation therapy. And yes, we have given palliative radiation therapy, and some patients have done well in the sense that we have probably improved their quality of life. Likelihood of fistulization, of course, it exists both with treatment and without treatment. Likelihood of fistulization does exist. Now, some other complications of advanced cancer cervix. So again, I'll just touch upon them because all of them by themselves are extensive chapters. Like pain. So these are all the complications which we see in advanced cancer cervix. They are devastating, they are distressing, and the patient it's unfortunate for the patient and the family. So there are plenty, but some of them which are important are pain, vaginal hemorrhage, and all of us have seen them. Enterovaginal, all kinds of fistulas, enterovaginal, rectovaginal, vesico-uretrovaginal fistulas. Uremias, DVTs, malnutrition, anemia, depression, despair. So all these are complications of advanced, untreated, unfortunate patients of cancer cervix. Let us talk about them, 1 or 2 slides about each. Pain in an advanced cancer, cervical cancer. What is the mechanism? The compression and destruction of nerves, invasion of contiguous pain-sensitive structures, infiltration and occlusion of arteries, veins, and lymphatics and bones, infection and inflammation and obstruction of hollow viscera. So all these are different mechanisms which may be the cause of production of pain due to advanced cancer. Now, how do we treat these pain? It is very, very important. We have pain clinics, but we cannot shirk our responsibilities because it is to us, most of the cervical cancer patients, they visit the radiation oncologists and they have all the trust in the world in us. So what do? We are the first doctor whom they contact. Reassessment of the pain. We have to reassess the level of the pain. Now, before jumping on to a pain treatment, this is very, very important. We have to rule out pain related to oncologic emergencies. So we may keep on giving anti-analgesics and NSAIDs, but if we are not aware, we may have missed something which is a treatable cause, an oncologic emergency which is causing the pain, like fracture, a threatened neural injury due to brain or spinal metastasis, an acute abdomen, and systemic infection. I think fracture is very, very common. So many times we have seen a patient who comes with a severe pain in the hip or in the leg, and she cannot move. And immediately we think that, oh, let us go for a PET CT and let us go for a palliative radiation. But many times just an X-ray is an answer. And in an X-ray, we pick up a fracture. And then for a fracture, radiation is not the first mode. We have to reduce it, and only then the radiation. This is just an example. This is just to stress that, yes, we should not miss out on any oncologic emergencies. So we have to be very careful regarding them. After we have ruled out all oncologic emergency causes, then other drugs which we have, the NSAIDs, narcotic analgesics, antidepressants, they have synergistic effects with narcotics. After all these are over, nerve blocks and transdermal elective, that is the TENS nerve stimulation. And after all these, of course, we have our palliative radiation, which is the answer to all pains, hemorrhages, or all these complications we are going to talk about. Deep vein thrombosis. This is something many times we do not give so much importance to this, but yes, deep vein thrombosis is a distressing complication. DVT, it may cause secondary edema, and if it cannot pick up, then because once treated, the edema may subside. So when the patient comes with a secondary edema, many times we focus all our attention, that's probably inguinal lymph node which has come back over there, and we keep on doing scans after scan to find a lymph node over there which is causing the edema. But yes, if we are not aware, then we have missed a DVT which is easier to treat. Anticoagulants is a standard treatment for DVT. Prolonged anticoagulation is often necessary, but yes, be very sure there are its own problems with prolonged anticoagulation. Anticoagulations may exacerbate hemorrhage because these are the patients who can have hemorrhage, so be very careful. Vena cava filters, nowadays it is inexpensive, but yes, vena cava filters, they are being used, and sometimes they are preferable to prevent any embolization to the pulmonary veins. Vaginal hemorrhage, this is also a very distressing complication, and many times it's life-threatening. It produces severe anemia and even death. It must be prevented. Vaginal packing is the first thing that we do. Palliative irradiation, embolization of the uterine arteries, surgical resection, arterial ligations, of the uterine arteries, and generally the anterior division of the hypogastric arteries are done. So these are the last resorts which are taken to stop the bleeding. So vaginal packing, I would like to mention here to all the students here, whenever you do a vaginal packing, do always mention when the vaginal packing was done. Do not forget, the patient may land up in sepsis. Do not forget to remove them. If the patient is going back home, do tell them or write it in a paper over there that the vaginal packing needs to be removed. So it is not the packing is done and you send the patient home. This has to be followed up. Another complication which is very frequently seen is hydrouteronephrosis and uremia. Now, what happens? The ureter, it passes lateral to the cervix during its course to the bladder. And the cancer in the cervix, an advanced cancer, it compresses it and produces hydronephrosis, ureteronephrosis, and ensuing, and this causes uremia, pyelonephritis, or rather pyelonephritis and edema, uremia. And this may be due to the fibrosis from irradiation, or maybe because of some surgical interventions. And what is the management? Dilatation, stenting, and very easy to do is a bilateral percutaneous PCNs, which can be done. It may be, of course, a cause of death. So this is about the hydroureter and how they should be treated. Now, the next is the vesicovaginal fistulas. So I'm sorry, I think this picture should have been in the previous slide. So the commonest fistulas which we come across in advanced cancer cervix are the vesicovaginal and the rectovaginal fistulas. There are many more. They may be caused by a primary, it can be caused by the primary or a recurrent tumor, or maybe a complication of surgery or radiation therapy. So the fistulas, it can be because of the recurrent tumor, and it also can be a contribution of our own treatment, surgery and radiation therapy. So being radiation oncologists, let us understand what is radiation-induced fistulas. By inducing, how is the fistula caused? It induces progressive endarteritis obliterans, and this resulting necrosis and breakdown of the mucosal surface. So this is how a fistula may be caused because of a radiation. Radiation therapy is associated with VVF is about 1% to 5%, and this can be seen even 30 years after treatment. And once again, I'd like to say the incidence has reduced with our conformal modes of treatment. How do we diagnose them? CT scan, MRI are invaluable for assessment of gynecological fistulas. So here you can see some images. You can see the fistulas, the complex air you can see here, and the fluid-filled, the rectovaginal fistulas and the vesicovaginal fistulas. So these are some of the images which you see, the MRIs and the CT scans. Both are very good methods to diagnose a fistula. What are the symptoms? Vesicovaginal fistula, there is urinary leakage through the vagina, and you cannot miss. Many times the patient does not say, and you take up the patient on your OPD table, and immediately you can smell urine, and you know that it is a fistula patient you have seen. So you cannot miss a vesicovaginal fistula if you are seeing the patient, that you cannot miss that smell, the urinary smell, uriniferous smell. That is the first symptom which leads you to the diagnosis of vesicovaginal fistula. There can be bleeding, there can be localized pain. How do you identify them? Yes, a PV examination. Many of them, I do not know how many of us, how many students have really seen or palpated a vesicovaginal or a rectovaginal fistula. But I would say if any of you students have come across a patient, do call all your colleagues, all your friends to examine this patient, because probably you will never get to see. So a vesicovaginal fistula, you have to feel it to not to forget it. So vaginal examination is very, very important. A cystoscopy, many times if you cannot, then a cystoscopy will be of value. Rectovaginal or colovaginal fistula, here again you'll have, here you have a uriniferous smell, here you can have a fecal smell. So there is involuntary loss of fecal material, gas and mucus through the vagina. And in the perspecular exam, you can feel the presence of stool, and it allows localization of the vaginal opening fistula. So you can actually feel it on your fingers if it is low enough. What is the management? Very small one, spontaneous closure is possible if a prolonged use of a bladder catheter is done. So small ones, the patient is fortunate enough, there can be a spontaneous closure. Surgical repair with grafts can repair complex fistulas. We have surgical diversions, and if nothing is possible, exenterations with urinary diversions, ileal conduit can be done, and pelvic exaggeration. So these are the various ways genitourinary fistulas are managed. But yes, it is probably not a very happy outcome. Now, these are the differences. This is again a very old study I found in 1957. And this is not study, it is actually an experience. So they have said that in their, it is a single institution study, the kind of anastomosis, palliative anastomosis they have done in their practice. They have done ureterosigmoid anastomosis, skin ureterostomies, transurethral resection of obstructing tumor, bladder fulguration, urethral dilatation, nephrectomy, nephrostomy, and ureteroenterovesical anastomosis. So these are the various procedures they had done way back in 1957. So this was the last slide, and thank you. I think I finished just at 9 o'clock. If there are any questions, I would be very happy to answer. And I would say cervical cancer, advanced cervical cancer is a preventable tragedy. The onus is on us how we are able to prevent them by educating the mass, by educating our patients.
Thank you, Dr. Swaroopa. So we haven't had questions. Yeah, so one question we have just had is, in re-radiation, what would be the indication as well as the target volume in nodal radiation, and what are the doses?
Yeah, so it depends. It depends on, like I said, when it has come back, that is the disease-free interval, not the disease-free, the radiation-free interval. When did you do the last radiation? And accordingly, you can see your dose, what you can give. So the criteria is the OARs. You can very well go up to 45 grays, 50 grays, but you have to see the OARs. And in a nodal radiation, that is a para-aortic nodal, I think you're talking about para-aortic nodal radiation. So the kidneys are very close by. So you have to see how much best you can give to the patient considering the OARs. But in most of the cases, we have been able to give from 30 to 45 grays. We have been able to deliver the dose to such patients, recurrent para-aortic radiations.
Okay, thank you. So ma'am, one question could I add from my side is, in case you are doing the re-radiation, and you are suppose you are indulging in pelvic nodal re-radiation, or there is a small volume in the pelvis. So are there any dose volume indications of the amount of final dose given? See, the patient has been radiated before.
Yes.
So is there a correlation between the interval between the two radiations, or between the dose that you intend to give and the volume of the target?
See, this has to be customized. It depends on the area you want to irradiate. There are no mathematics like this, but everything has to be correlated to the disease, the patient, and the previous dose. So I don't think there is anything where you can actually say. You have to see how much the total BED to the OAR are, like in the bladder. So probably it can take up to about 120, 10 grays it can take. And the rectum it be maybe a little less. So that way you need to, the point dose or the maximum dose to the bladder or the rectum, that needs to be taken into consideration when you want to prescribe the dose. And again, the dose per fraction, that is whether it is 2 grays per fraction, 3 grays per fraction, they have to be brought down to the EQD2. And generally, we need to see what the alpha beta ratios are. Generally, we take it as a 3. So all these things need to be taken into consideration when you are planning the dose to a re-radiation to a particular area, be it in the pelvis or be it in the para-aortic area.
Thank you, ma'am. Thank you again. And we haven't had a lot of questions for recurrence. It's actually a rare topic, and people they just read it towards the end after they have already gone through the rest of the cervix. So one question is again on recurrences: is there a dose cutoff in case of second radiation?
No, again, everything boils down to the same fact: your OARs. You have to protect your OARs. Like there's a question here on cobalt re-radiation after previous radiation, the minimum duration. So again, we would, after a cobalt re-radiation, we would probably want to wait for about 8 months to 12 months. But again, if you want to re-radiate and if you have a conformal radiation in the second re-radiation, you could go ahead with a radiation even before that. And again, the dose will again depend on the OARs, what the OARs have received previously.
Yes, ma'am. Yes, ma'am. Very rightly said, ma'am. Ma'am, any words on just the use of, say, interstitial radiotherapy as a second radiation, or on the use of for example, intracavitary radiotherapy for an isolated vaginal recurrence?
Yeah, I think it is easier when a vaginal recurrence is there or a cervical recurrence there for irradiation. It is much easier to treat it with an interstitial or an intracavitary brachytherapy. You need to decide whether you want to give an intracavitary or an interstitial. It will depend on the tumor volume. Like if it is a vaginal recurrence, then probably you can't do with an intracavitary, obviously, and you need to put in the needles. So it is brachytherapy is the most conformal of all radiations. So in such cases, you're probably lucky that you have the option of an interstitial or an intracavitary brachytherapy instead of an EBRT, where you need to treat a larger volume and you need to take into consideration many more factors than individualized brachytherapy.
Thank you, ma'am. And for our young people here, what should be the volume contoured in case of a re-radiation for recurrence? If we are planning to radiate it, what should be the contoured volume, target volume?
So usually we are treating the gross tumor. We are not giving radiation. If it is a radiation in the treated area, that means in field recurrence, we are treating only then whatever studies we have, they have treated only the gross tumor area. They have not given any preemptive radiation anywhere else, or where like in the nodal areas we are not giving, only to the gross disease which has come back in field. We are treating only that area. That is the treatment volume.
So, thank you, ma'am. I don't think there are any more questions. Dr. Shaleen, would you like to put in any points, sir?
So, first of all, thank you, Dr. Swaroopa. That was a fairly tall order for you, and I accept at short notice as well, particularly with regard to the latter two topics. Now, I noticed that obviously we're looking at recurrences. And since this is a radiation oncology community, a team of radiation oncologists who are basically listening in. So it may be just at the small cost of repetition, generally talk about principles of re-radiation anywhere, and cervix is probably no exception. So I can see the question that is coming, the questions that are coming up are dose, volume, timing. These are typical questions that people are asking, and rightly so. So fundamentally, I think if you're looking at re-radiation at any site, one of the most important things is time since first radiation. The longer the time elapses, the better it is. And the more critical the structures involved, the longer time you expect. So for instance, in CNS, we typically look for more than a year and a half. In head and neck also likewise, we're looking at least for a year. Same here in cervix. Now, there is one thing that I remember having read and that we sometimes follow is that if the disease-free interval between the period of completion of the first radiation and the detection of relapse is too short, you can sometimes buy time with adding chemotherapy. Okay, so that sort of increases the duration. The second decision that one takes is by assessing the impact of damage and late sequelae in tissues at any site, clinically. So if you have impact, if you have a greater impact of radiation, if there's a greater radiation sequelae, if the late radiation sequelae are already pretty high, you will tend to scale down doses. The third thing is the disease resectable or not? Because invariably, larger diseases are not resectable and have a poorer outcome. And to large volumes, you cannot give large doses. Fourth, I would completely agree that you only treat the gross disease as much as you can, give highly conformal treatments. That is the fourth thing. And of course, finally, the question is, do we have alternatives or not? So here the only competing alternative, worthwhile competing alternative is surgery. The better alternative of radiation, as you have repeatedly pointed out, and I agree with you, is highly conformal radiation, which is brachytherapy. That I completely accept. And finally, taking the help of chemotherapy to potentiate the effects of radiation is sometimes tried, and particularly here. And you also use chemotherapy to buy time if you are too close home, too close to the first radiation dose. So thank you very much. And I mean, it was obviously challenging, and thank you very much for your time. And if there are no further comments, as I can see, there are none. On behalf of, okay, so somebody is asking a question. Was the role of concurrent chemo in RT not amenable for surgery? Is there any data on this, Dr. Swaroopa?
Role of concurrent chemo in RT in a prior radiation patient not amenable to surgery. I'm not aware. This is quite a relevant question. And we are still wary of, for irradiation using concurrent chemo, we are a little wary, but probably later on we'll have more data and we'll be more brave enough to use chemotherapy along with radiation, but not now.
But we use chemotherapy to buy time before you restart. That's the important
absolutely,
point.
Absolutely.
That is relatively reasonable to do, because you do need disease-free intervals that are longer, looking at half times of repair, etc. Not half times of repair. These are not half times of repair. These are looking at, well, basically clinical data on, you don't re-irradiate too soon. Otherwise, you can have catastrophic injury to tissues. Okay, thank you very much, and thank you for your time, and thank you, Ashutosh, for that moderation. And let's sign off for today. Good night, everybody.
Good night, sir.
Good night, sir. Thank you, Dr. Swaroopa, and I would thank all the participants.